Thanks everybody for coming. We're very honored today to have Joseph Caprini come from Chicago to talk to us about PE and DVT. In late 2011 and on through 2012, we noticed the spike both here and over at Kaiser in our incidence of PE and DVT. We looked at many ways. Couldn't find necessarily a common cause. We couldn't find anything that we were doing different that would cause us to have this spike. So in a shotgun approach, we looked at many different things and attempted to work on a few different projects. One of them is the scoring system. So Dr. Caprini is out here to talk about the work that he's done throughout his lifetime in VTE prophylaxis. We had a special session last night with the orthopedic surgeons, which was taken a lot better. He didn't take any pot shots from Ruth and her crew. Anyway, so I'll let Dr. Caprini introduce himself, as he always has an entertaining way of doing it. But thanks again for everybody showing up.
Well, thank you very much, and thank you all for turning out. I hope that this will be beneficial for you. And excuse me, the reason I wanted I'm so excited about this is that I've worked my whole life on creating what I call my box. So, maybe contrary to a lot of other speakers, I'm not trying to convince you of anything. What I want to do is share with you, and I'm out of medical school 47 and a half, almost 48 years, and doing this for 38. I want to share with you the box that I have built over all of these years. Some of you might like the box and want to jump into it. Others might not want to get into the box and maybe want to shove the box over the side of the cliff. I really don't care. What I want to do is make sure that I've explained to you my box. Now, my box starts it actually really started in Great Falls, Montana, because I was a surgical resident and I was in the Berry clinic because I was a poor kid. And I was drafted during the Vietnam War, and I was sent to a sack base in Montana. Being the junior surgeon, the senior surgeon says, "Caprini, you're doing the tonsils." And I said, "Oh my God, I'm going to operate on a bleeding kid, and it's going to ruin my career, and the child may die," and so forth. So I started studying blood coagulation, and I had the sergeants do 5 screening tests on the kids before the surgery. And lo and behold, 10% of them had abnormal tests, so I never operated on them. And they all came down here to Fitzsimmons at the time and got worked up. But anyway, I'm back and did my general surgery, did residency in those days. We also did vascular tumor, some pediatrics, pyloric stenosis, ureteral reimplantation. We did everything from A to Z, and probably none of it well. But anyway, I did the same research project during my residency, picking up bleeding patients, and I was able to pick out a third of 54 patients who had clotting abnormalities, and I canceled their surgery as a junior resident was the attending. And that was really worked out well. So when I was finished, I was asked to go, and I did a year of coagulation at the medical school, and I came back and I had started this lab, and so I ran a clotting lab for the Department of Surgery. At the same time as doing general and vascular surgery and so forth for the next 25 years, and then also started the vascular lab, and then even up to today. The coagulation lab closed in the late 90s because people weren't, with cost cutting and everything. That was a problem. Plus, I was never managing it or anything, but it provided a really good service. In any event, what I'm trying to tell you is, as a part of this box, we have general surgery, we have vascular surgery, tumors, good God, hematology, vascular, and then into swollen legs and DVT. And in the 80s, when I was putting in vena cava filters, 19 out of 20 patients that came in for that I was requested to put a filter in, I didn't do it because I was a clinician and would have to take care of the problem. Today, if one of our vascular surgeons comes and you ask them to put a filter in and they say, we don't think we ought to do this, they'll call IR and it'll be in an hour. The trouble is, when that limb extrudes and causes an erosion into the duodenum, then we have to go in and try to take care of that. They don't have to do that. And having been there before, that's something that I certainly never want to do if I can avoid it. So anyway, that's my little box. And based on that, something else happened to me too, and that is that I decided, because of some bright people around me, that all people may be created equal, but not all risk factors. Some are very low risk, some are very high risk. So we started to experiment with a risk assessment scheme in 1986. And now finally in 2013, I think we have something. It's not perfect, but it's your secret weapon to pick out many of those people at very high risk. The first thing I'd like to talk about, which I think is important in my box, in the orthopedic box, they're concerned with clinically relevant pulmonary emboli during hospitalization. I think in the general surgical box, most people are concerned about DVT and PE events that happen during hospitalization. But I have a different box. The box, of course, starts with what we usually talk about. And here's an example. Patient presenting to the ER, non-productive cough, wheezing, dyspnea, moderate back pain, and for 5 days. And the patient developed a massive PE and died 3 days after admission to intensive care. There's the PE. The patient didn't get prophylaxis. Now, and some of you may know Victor Tapson. He's a famous pulmonologist, chief of pulmonary medicine at Duke. So this is an armpit general. And the reason why these kinds of things happen is these patients, when they come in, are so complex and there's so many things going on. It's not that the students are stupid. Oh, I have another disclaimer. You know how people make disclaimers before their talk? I'm a Sanofi consultant, I'm a Berger Ingelheim consultant. Well, my disclaimer is that I'm a B student. And as a matter of fact, my wife looked at my transcripts and said, Joe, how can you tell people that? I see a few C's in there. It's true. But for some reason, I have this passion for this stuff. This is all, I can't tell you the difference between a second degree and a third degree heart block. I can't rattle off the best new antibiotics for MRSA, but I know this stuff. And so that's my disclaimer. In any event, what this is entitled, this first section of the lecture, is the many faces of venous thromboembolism. Sure, it's clinically relevant to fatal pulmonary emboli, but it's also things like pulmonary hypertension. And to a West audience, a Western state audience, that's got to make a lot of sense because a lot of people here in the West, including myself until I broke my leg, we like to hike and ski and do all those outdoor things. And if you have a pulmonary embolism, you may be restricted from doing that as you go down the road. And if you did a gallbladder on that patient 2 years before, you don't have a clue because that's not your job. And the other thing I would like to say is, before we get carried away, and I think that this really holds true for surgeons, and that is, to be a good surgeon, you have to have focus. You got to have your eye on that target. And if there's somebody helping you with a difficult case and they're fumbling around like mumbly peg, you can't pay attention to that. If there's some distractions, if there's a nurse that's not giving you the right stuff, or if the instruments don't work, you can't pay any attention to that. You got a job to do. So that's all extraneous. That's how we're trained. You go into the emergency room in the old days, before we had CAT scanners, MRI, or any of that stuff, excuse me, when you examine an abdomen, and that patient's got peritoneal irritation, and signs of peritonitis on good, careful physical exam. You don't give a rat's what the white count is. You didn't care what the x-rays show. Oh, it's nice to have it. And of course today, it's God's law that you can't, they didn't even call you for the CAT scan. So hopefully, you know. But anyway, the thing is, you have focus. That abdominal surgeon focuses on that abdomen. And they see peritonitis. The sun never sets on peritonitis. You got to operate, blah, blah, blah. So anyway, when I say all these other things about this is all I'm focused on now, because after 32 years I don't do surgery anymore. So it's very important to know your focus. And that's why it's so exciting for me to come and talk to you, because I have another disclaimer, which has taken me a long time to figure out, because when I was a resident and when I was attending in the early 70s, it was absolute sacrilege to talk to another attending, or to get another attending to come in and look at a difficult case, look over your shoulder and say, hey, what do you think? That was blasphemy. That was a sign of weakness. And of course, that was also ridiculous. I notice our surgeons today, they network. Sometimes there's 3 or 4 of them in the room trying to figure out what's going on. Because you know what? It's a very difficult job taking care of people. And the other thing is you don't get another chance. And so one of my other disclaimers is I've finally figured out that life is a team sport. And it's with that in mind that I come and talk to you today. I'm not trying to lecture you on stuff specifically and tell you, you know, you should know this, you should know that. No, 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 no. I'm trying to be a good team member and bring you my box for those of you that are interested. And you know, everybody has different experiences, and you may have different ones. But anyway, my box includes the many faces of venous thromboembolism. Here's another face. That's a clot in the right atrium. Clot broke off from the legs, goes to the right atrium, dilates a patent foramen that normally isn't functioning. Clot slips through, goes to the brain. Patient has a non-hemorrhagic stroke. That could be from a DVT. It's another one of the many faces of venous thromboembolism. 25% of the normal population has a patent foramen or valley. 50% of the people at any age that have cryptogenic strokes, strokes of unknown origin, 50% of them have a PFO. Now, that's a true unrelated. So I'm not saying that every time there's a cryptogenic stroke, it's due to a patent foramen, but there is an association. How about this? We don't see this very often. This is a lady that came in. She was given intravenous heparin. She was started on Coumadin. And what happened to her is that her leg got worse. She developed necrosis, eventually lost the leg, lost her life. I think this was a case of heparin-induced thrombocytopenia with superimposed Coumadin-induced skin necrosis. It's it's not a very common complication, but if it happens to you, it can be serious. Another one of the many cases. This is a picture that I see endlessly. You know, it's very characteristic, and I have fit the mold for the older surgeons that have quit surgery but were still walking and talking to work in wound centers and to take care of wound patients. So that's another part of what I do these days. There isn't a day goes by, and I see 40 to 50 people a week yet. I flunked retirement. You know, for rich or for poor, in sickness and in health, but never for lunch. My wife is happy with that. I see these every day. I see these people every day, and they're flocking around. And a lot of them have, and then we had to take a history. And a lot of them are, have a history of. This lady had 2 joint replacements. She had a clot after one, and it was 10 years ago. So it's like out of sight, out of mind. Here's another out of sight, out of mind. 38-year-old male suffered a fracture. And oh, I didn't make this up. And the other thing is, all the disclaimers are coming out, you know, it's a good thing my wife isn't here, but she would say, you know, it's characteristic to, I'm a great embellisher. And because I'm in the West, I've had the good fortune to know Warren Miller. And I was at Warren Miller's house one time, and I don't know, I'm nobody special, but I'm a buddy with his doc. So his doc said, come on, we're going to go visit Warren. And so we're sitting there visiting Warren Miller, and Warren Miller is regaling us with one of these great stories. And you know, Warren Miller, for skiers, he is the consummate storyteller of all time. And he's going on and on. All of a sudden, Laurie interrupts. No. She says, that wasn't the way it was. And I said, ma'am, I just met you, but would you be quiet? This is a great story. Don't mess it up. Well, this isn't a great story. This is exactly how it happened. 38-year-old male, he had a fractured leg, he developed DVT, followed DVT. He was in a cast, and this is his leg 10 years later. Where's the orthopod? Of course, nowhere in sight. We can't keep track of the patients for 10 years. But look at what happened to him down the road. It really can happen. It really does happen. We see it all the time. So, the other thing is that there's now a point where I must say, after all these years, I am truly astonished. And the reason I say that is that 15,000 people die of AIDS every year, 40,000 people die of breast cancer, 95,000 people die in auto accidents every year, and 300,000 people die of fatal pulmonary emboli, a third of them presenting a sudden death. Nobody seems to care. I'm sure that most of you have never even heard about the call to action by the Surgeon General, the least known, least publicized, least acknowledged, least followed up upon, I sound like a politician, call to action in history, VTE. And the other thing is that when is the last, we just had this terrible thing happen at the Boston Marathon. What a nightmare. But how many 10K runs for thromboembolic disease have you been to? For a disease that kills 5 times more people every year than breast cancer. I don't get it. I still don't get it. So that's why I use the word astonished. We talked about pulmonary hypertension as one of the many faces of DVT. We talked about clinical venous thromboembolism and the rare HIT-induced thrombosis. Also, phlegmia cerula and albedolins, when there's such a large clot in the leg, it can actually interfere with the arterial supply. Happens about 0.5% of the time, but if it happens to the patient, that particular patient, then it's a problem. And then here's the other one. I want you to remember this. This is the Groucho Marx face of venous thromboembolism. And a lot of you are too young to remember this, but Groucho Marx was a very wry comic, and he would play doctor with a mirror on his head, stethoscope around his neck, and of course, the inevitable big cigar. And the guy would come in and say, "Hey, doc," every time I go like this, "It hurts." Doctor would say, "Don't go like that." "No, no, no, doc. No, I had it before. I've got it again. I can't work. What can you do for me?" "Well, I don't know what it is, but you've got it again." And I want you to remember that forever. And the reason I want you to remember that is that if a person has a DVT after an operation, even if it's a silent one, the next time they have another operation, their chance of another DVT is about 65%. And we may do things, and they may come to somebody like me and I do all this fancy stuff to prevent a blood clot afterwards, and they still can get a blood clot. And I think the never events are rubbish, because in the patients with a previous history of thrombosis, they very likely will get another thrombosis. Now, if you protect them properly in my box, they're probably not going to die. So, what I want you to do is everybody raise your hand. Don't really raise it. Mentally raise your hand and promise me that you will never, ever, ever see another patient without asking them, have you ever had a blood clot in the past? Is there a family history of a blood clot? Those 2 questions. And every time, and if somebody answers yes, "Oh, you had it before, you're going to get it again." Remember that. That's very important. Another face of venous thromboembolism. There's the stroke that we talked about, the paradoxical stroke. By the way, Sharon from Israel had a paradoxical embolus. He was on Coumadin and he had a cerebral bleed. So it wasn't a primary stroke in the brain the way it was reported. It was a PFO thrombosis from the deep vein thrombosis. And 50% of people disabled, 20% die, 30% recover. But the blockbuster is the post-thrombotic syndrome. It's a permanent disability. It may take 2 to 10 years to develop, and it is a major source of morbidity and mortality. So, orthopedists have their box, general surgeons have their box. This is my box. These are the many faces of venous thromboembolism. Now, I grew up at a time when the air was clean, sex was dirty, and you spoke only when you were spoken to. I remember getting sent home. Excuse me. I remember getting sent. The nun sent me home from school, and my father beat the crap out of me. "Don't you ever come home? Don't you ever have?" They didn't care what happened. They didn't. Maybe the nun was having a bad day. They didn't care about any of that, you know. And I never got sent home again. It worked. Everything is different today, including the fact that that after working on this risk assessment for all these years, the #1 objection and the #1 objector is in San Diego, is the fact that it's too complicated. Well, I have a question for all of you. So I got to tell you this. I have a dear friend, and there's an iPhone sound that goes, and she has that for her emails. Isn't she in the gynae position? The gynecologist ready to do the examination. As she opens up, the thing goes. He jumps back. Are we having fun yet? You're not ready to start to me, is that? So anyway, so how in the world would a physician ever see a patient and try to do something to that patient without finding out if there's anything that could jeopardize the outcome of that procedure? Which means, how could you shortcut the history and physical? If you're too busy, get somebody else to do it for you. Well, I have a suggestion. If you fold the patient into their own health care, like that form we sent around from the Illinois Medical Society, those patients can fill that form out before they even see you or while they're sitting around in the waiting room. And then your assistant or yourself or whomever can touch up the form and very quickly figure out all of those factors which will be important for the patient to know. And while we're on the subject, don't just start counting points till they're high risk and then stop. That's amateur hour. And I'll show you why. And the other thing is, God forbid the CAT scanner is broken. So you'll have to do a history and physical. But you can get help by doing that. And in our system, we have a thing called North Shore Connect with our Epic system that the patients can get into and make appointments and talk to their doctors and so forth. We're putting that in there, and the patients are going to be able to fill out their risk and send it to the doctor. So even before they get there. And the other thing is with electronic medical record, my hospital is in the process finally after 25 years, we're going to try to embed a lot of these things that are already in the record so you don't have to double ask. And now we're going to get into some Yogi Berra-isms.
Can you check your mic, please?
Oh, is it working?
We're looking for another battery.
Oh, okay. Oh, yeah, because it went out.
You know, Yogi. If you're coming to my house and you come to a fork in the road, take it. Turns out both forks of the road went to his house, by the way. You're sitting in the barber chair for the Affleck commercial. You know you can get a cash rebate and spend it just like money. The one I like the best is, you know about golf. Golf is 90% mental, but the other half's physical. Well, believe it or not, the more risk factors you have, the more likely it is you're going to get a blood clot. And the more powerful those risk factors are, cancer, thrombophilia, previous thrombosis, the more likely it is that that particular risk factor, that particular risk factor is going to be responsible for causing a thrombosis. Okay, so this is really very simple. I told you I was a B student. This is not rocket science. And just to add up risk factors and say the patient has a risk, it's like adding up everybody's weight in this room and dividing it by the number of people and coming up with a number. It's nonsense. This all started, thank you very much, all started with Fred Anderson, that these are 1,250 patients that after they went home from the hospital came back with a DVT. And so Fred took a look at this, and Fred showed that as the number of risk factors goes up, that the patient has a higher chance. There's this famous curve now with risk factors. And he also showed the weighting. And he said 1 or more risks, 2 or more risks, 3 or more risks. And so this is where it all started. And believe me, this is not rocket science. You young people, you're not going to get clots. It's very rare. Us older folks, Jesus, I'm on this curve and I'm heading up fast. Ejection fraction. As the ejection fraction goes down, the DVT rate goes up. Again, non-rocket science. It was interesting because my internist, I was talking to I have this wonderful internist, and I go into the internist and he's explained to me how the data on the Lipitor and so forth is flawed, the statistics are flawed. And before I knew him well, I didn't figure it out. Well, it turns out he's a rocket scientist. He got a PhD in physics, but then he met this girl and decided to go to medical school. So there are some rocket scientists out there, including my doctor, but it's not me. So we take the score, and the thing that is, so first of all, additional disclaimers. I'm in love with Nisquik. National Surgical Quality Improvement Project, of which you're a card-carrying member, of course. I'm not in love with SCIP. I think it's a governmental policy that's flawed, and I'll show you the data. You know, SCIP, you got to give a shot of anticoagulants within 24 hours of the operation. And so, what I think is really important is to take the score and compare it to the real outcomes, the proven DVT rates. We're not talking about screening, we're not talking about pediatricians, duplex scans. We're talking about people that get chest pain, shortness of breath, leg pain. They're found to have a clot. What's their score? When did it occur? And the reason I'm in love with Netscope, of course, is because they're tracking 30-day data on all of this. I wish it were 90, but you know, I wish I could ski again. I had a very bad fracture. I was working on the patrol for 8 years as a doctor because I decided that I had done enough of this, so I was only doing it part-time. And I came to a crashing end one day. I'm back doing this, but in all honesty, I have to tell you that I really wouldn't take it back. And you know the reason? Look at all of these heads. And you take, especially these young people, just how many people do you, how many patients do you think each of you young individuals are going to see in your career? And if I could give you even one or two little tips or pointers to help you take better care of your patients. Good Lord, I can't think of doing anything better than this. So I'm really, really happy to be here. I'm honored to be here, and I'm very happy that you haven't all run for the doors yet. That's really terrific. Here's the scoring system. This is developed for patients and for doctors alike. The Illinois Medical Society has decided to make this an initiative, and we can supply you if you want. They printed up 10,000 of these. We can supply you with an endless number of these that you can put in your offices, you can put in the holding area, you can put in same-day surgery, and they can fill this out. And on the reverse side, you know, it explains about DVT. And so you just have to let the authorities know. We'll get you all of these that you want. This is a secret weapon. It's involving patients in their own health care. And as a matter of fact, think about it when you go to the dentist. They're not going to touch you. You have to fill out your whole health history, your medications and so forth. Doesn't that give you a good feeling to know that you can tell the dentist something about you that may impact your care? Well, just think how much more important it is what you folks do in surgery compared to the dentist. Now, I'm not belittling the dentist, but I'm just saying it. You've got some real big time decisions to make. You've got some big time operations and so on and so forth. Anyway, involve the patients in their care. General surgery. Thank God for the University of Michigan. I was flopping around like a fish out of water for almost 20 years, and people would say, boy, he's a great speaker. But you know what? He just pulls all this stuff out of the air. Where is the documentation, other than, you know, what the institute, how does he get the score of this and score of that? So the University of Michigan said, yeah, let's take a look at this. So they studied 8,200 patients in the NISQIP program for with 30-day outcomes. And as you can see, the incidence of DVT is very low here. And up to 4, oh, in case the fire alarm goes out, goes off, and we all run out of here at top speed. Here's the punchline. Anything less than 4, don't touch them with anticoagulants. Depending on the category they're in, from 4 to 8, if they need prophylaxis, oh, here comes Yogi again. If you're going to provide prophylaxis, don't you have to provide prophylaxis for the period of time that's been shown in randomized clinical trials to be efficacious? That's a week. That's not 1 or 2 days. There's no data in the world that indicates it. 1 or 2 days, 1 or 2 shots of low molecular weight heparin does anything for efficacy. Increases the bleeding, sure, but doesn't do anything for the efficacy. So between 4 and 8, give them a week of prophylaxis, and especially if it's over 8, then 2 to 4 weeks of prophylaxis. That's what I do in my own clinical practice, and that's the punchline. And as you can see in the Michigan study, once they get up into the teens, almost everybody gets a clot. And you can use this to, oh, and the other thing is, just like I'm talking about a box here, and believe me, I'm not trying to force you into the box. You've got to voluntarily walk into it, or you've got to voluntarily walk away, or you've got to kick it over the side of the hill. Do whatever you want with the box. But I do the same thing with the patients. After all my experience, sir or madam, this is how I feel. This is what I think you ought to think about. If you don't want to do it, I will still do my very, very best to take care of you. But just keep in mind that your choice may not be my first choice. I'll still take care of you, but here's what I suggest based on the numbers. And that's what I think you have to present to the patients. You know, you can't force anything down their throat. They are the patients. They have to put up with the treatment, and they have to make a decision for themselves. It's just like the lady. I can't believe this story yet. This lady was 350 pounds. God bless her. She lost weight. She had bariatric surgery. She had a previous history of thrombosis. Her mother had a thrombosis. She had a Leiden defect. She comes into the office, and she's going to have a paniculectomy. And she had like a Caprini score of 20. And I said to the lady, I gave her my speech, and blah, 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 blah. And this was before the days. I have another thought for all of you folks that I've used, another little trick. I don't do a high-risk consult without a loved one present. Because the patients will say whatever they want just so you operate on them. I can't stand this, got to operate on them. That's what this lady, I was getting nowhere with this lady that didn't have a loved one. So finally I picked up a piece of paper and I said, Madam, this is United Airlines. This is your boarding pass for your next flight. And right here, down at the bottom, now read that carefully. There's a 5% chance that this plane will crash. Deal or no deal? Are you going to get on this airplane? What she told me, I can't believe. She says, Dr. Caprini, it all depends on where it's going. I'm not making this up. My plastic surgery colleague says, Joe, we can't stand anticoagulation because it messes up our wounds. And thank goodness I had a dear friend, Laurie Cassis, who's a wonderful plastic surgeon at our institution, and she was a believer. And she got the American Society of Plastic Surgery, and then also Chris Tonucci, who's probably the finest resident that I ever met. They got together and they got the American Society of Plastic Surgery. They got 5 universities together: Minnesota, St. Louis, Michigan, Texas, Pittsburgh. And they had a consecutive series of 1,126 patients with a Caprini score of over 4 who had surgery, plastic surgery. It was inpatient surgery, but most of them went home within the day. And they followed them for 60 days. And look at this. 11% of them turned up with thrombosis. Renal thrombosis. This is not screaming. And that, of course, has changed the entire practice of the American Society of Plastic Surgery, which now endorses prophylaxis. But again, hey, look at the numbers. Even up here at 5, your bleeding rate from anticoagulants may be more than that. So you may use physical methods. But once you start getting up on this scale, things really start popping. And here's another example of this. This, to me, I'm sorry to keep using this word, but this was truly astonishing. This is otolaryngology of 30 days. And as you can see, again, you wouldn't give any of these patients low molecular weight heparin, would you? It doesn't make any sense. And if it's violating skip, I got an answer for this skip thing. You write it out in the chart, and you can make it a smart quiz. In my opinion, the risks of anticoagulants in this patient are greater than the risks of thrombosis. The risks of anticoagulation with bleeding are greater than the risks of thrombosis from preventing the bleeding. Therefore, I respectfully decline to give anticoagulants. That passes skip, that passes Jacob. And the thing is you can make an individual decision because that's what's known as the practice of medicine. Now we go to the ICU. It's amazing. These curves are always the same. Numbers are slightly different. And what's not on here is the over 8s are 11% at discharge from ICU. They're probably even higher. So, now we come up to an interesting thing. And you know, God bless the internists. And I did a year of internal medicine too. I like to not talk about too much. But it was very good because it taught me how to do histories and physicals for one thing. And sort of got me started on this. Well, in the chest consensus document, Padua is the king. And of course, Sam Goldhaber and Kuchar are the capo di capos. And so this is a 4,300 bed hospital in China. And they did the risk assessment. And they had several hundred patients with known thrombosis. And they compared them, these were medical patients, as well as surgical patients. Which one of the scores picked up the most high-risk group? Because that's really it. And the Kuchar score, 8%. The Dewis score was better at 23, but we picked up 78% with our score. So it's been well shown, not well shown, somebody will say, well, that article's garbage, you can't try to think about it. What can I say? You know, there's people who are probably a lot smarter than we are when you come right down to it. I mean, you know, our whole world is made here. I have a ski park from LL Bean, a Maine State Park. And in the back of that thing it says Made in the USA. Of course, I bought it in 1980. Anyway, the thing is that the Badua score is now the recommended score for medical patients. It's flawed. I'm sorry. And so this is what CHEST came up with, which is a good start. But in their zeal, they overlooked the over 8 population. Why didn't CHEST also talk about the over 8? So they just recommend if it's over 6, they're high risk. These are the numbers without prophylaxis, according to the CHEST analysis. Now, by the way, in about 2 weeks, this will be an app. It will be available. It starts on the iPad. And the reason I kept it exactly like CHEST, because if anybody starts throwing darts at the app, I want to redirect them to CHEST. So that the Caprini app will absolutely mirror what it says in CHEST 2012. But, again, if the fire alarm goes out, I repeat, I've got 3 buckets. I've got people who have a score of even up to 4 or so. It depends on the patient. But low scores, you know, watchful neglect, intermittent pneumatic compression, early ambulation. 4 to 8, 5 to 7 days of anticoagulants, just like Yogi taught us. You've got to protect the patient for the period of time that it's been shown in randomized clinical trials for them to be at risk. And then risk score of over 8, 14 to 30 days, depending on the circumstances. Okay, we're all worried about bleeding, and of course, nobody is more concerned than the orthopods. And I always like it, I get a kick out of it when the internists get up and present data with these randomized trials. And some of these people that are being paid for by the drug companies, rivaroxaban, for example, is a better drug because there's less bleeding and so forth. And there's some more astonishing things. I have to tell you one thing. There's 4 trials with the rivaroxaban in orthopedic surgery. And they all show that there's a statistically significantly better thrombosis prevention than low molecular weight heparin. And the bleeding rate is less. Except, and you're not going to believe this, they excluded surgical site bleeding. What's the first, second, third, fourth, and 19th thing that a surgeon, especially an orthopedic surgeon, thinks about as far as his surgical or her surgical operation? It's surgical site bleeding. This patient will probably never have a normal function of that knee because of scar tissue. So I'm very sensitive to that. Now, take note of this. 33,000 patients. Low molecular weight heparin, unfractionated heparin, and watchful neglect. Incidence of wound hematoma, 4 and 5%. Incidence of mucosal bleeding, 2.6 and 3.4%. So, in the Caprini box, I only give anticoagulants when the score is such that it makes at least a 50-50, at least balances the risk. So if the chance of a clinically relevant thrombosis is than 3 or 4%, I'm not giving that patient low molecular weight heparin because I don't think it's worth it. You'll get more bleeding than you will for thrombosis prevention. Oh, this is cool. Skip. 2 skip measures. You have to give the anticoagulants within 24 hours before or after surgery. And those people need to receive anticoagulants except for those with high risk of bleeding. And the second outcome is intra or postoperative VTE that was diagnosed during the index of hospitalization or within 30 days after surgery. Now, as I told you, you can create a smart phrase for your disclaimer if you want to individualize your treatment of these skip patients. If you have a patient come in, you're going to do an outpatient procedure, and their risk score is low. The risk of bleeding from anticoagulants exceeds the risk of protection from this anticoagulant, so I decline to use it because there's more of a risk of bleeding than there is of thrombosis. That will pass the skip criteria. But here's the kicker. 30,000 patients. Operations from 2006 to 2009. 89% of them followed a skip protocol. Incidence of DVT clinical was 1.4% within 30 days. 11% didn't comply. Incidence 1.3%. So this didn't lower the incidence of DVT. And that's why I'm urging you, for the best care of your patients, to develop a smart phrase. Because you only want to give that when there's a high risk, and then you're going to do like Yogi would do, and you're going to give it for the period of time that's been shown in randomized clinical trial to be efficacious to really prevent the blood clot. Hello. Let's talk about a couple of patients. I love real patients. As much as research and stuff that I've done, I'm at heart a clinician, and it all comes to roost with the patient. 39-year-old female, uncomplicated lap chole lasting 70 minutes under general anesthesia, no other risk factors, and a BMI of 25. Thrombosis score is 2. Incidence of chest, estimated incidence is 1.5%. Low risk, recommends pneumatic compression. The documented bleeding rate I just showed you in the 33,000 patients. 4%, 3.4%, 2%, 1%. It's not worth it. Don't give that patient anticoagulant. Injection site complications, allergy to the drug, heparin-induced thrombocytopenia may occur anytime. Plus the fact is, you're also doing the patient a tremendous disservice. It's like taking an antibiotic for 3 or 4 days because you've got a quote-unquote cold. And that creates resistance for the future. Well, repeated, and this isn't talked about enough, repeated exposure to low molecular weight, even low molecular weight heparin, unfractionated heparin for sure, but even low molecular weight heparin, repeated exposure engenders the eventual development of an HIT, heparin-induced thrombocytopenia, which is a life-threatening complication. It's a nightmare. It's a nightmare if you have to do vascular surgery and so forth. So be very careful with these anticoagulants. And of course, like drug companies, they want you to use it from everything from the beginning to the end. But be mindful of that. It's not free of complication. There's the wound hematoma without the use of anticoagulants. Now, here is Nancy. Nancy's 42-year-old, ruptured her left Achilles tendon, running after a kid trying to steal her son's bicycle. Her BMI was 32. She was taking birth control pills, had a history of inflammatory bowel disease, was taking IV Remicade every 6 weeks for the past several years, and had a major bowel resection in the past. None of which was in the preoperative physical. She underwent uncomplicated Achilles tendon surgical repair and was placed in the leg cast. Age over 40, overweight, birth control pills, inflammatory bowel disease, leg injury, surgical repair, leg cast. Beautiful young woman running after a bicycle thief is a nightmare from a thrombosis standpoint. She's a very high-risk patient disguised in a beautiful low-risk appearance. Having a minor operation compared to joint replacement, and you know what? We never see thrombosis after those operations. Well, sure, if you take everybody, not everybody has high-risk scores. This is the secret, how to pick out the Nancys. Incidence of venous thrombosis without prophylaxis is 6% with a score of over 5. We know that, recommend anticoagulants. And here's my chart. This, to me, is the most important chart. With those numbers, this lady needs to be protected for the period of time that she's at risk. And how long is that? Until she is walking normally. Let's get back to that in a minute. 4 weeks later, now this is real. This is not fabricated. I've seen 100 of these at different variations. I showed the orthopods a different, happier variation last night. 4 weeks later, the cast was changed, and she experienced anxiety, and her nurse practitioner was very sympathetic and sat with her for half an hour, discussed all of this, and decided because she was going back to work, she was stressed, and gave her some tranquilizers. 2 weeks later, she collapsed and died at her daughter's graduation. Autopsy showed bilateral pulmonary embolism. Classic example, high-risk patient, low-risk scenario. Surgical procedure is normally associated with few incidents, but using the score is a valuable asset. Okay, so practical suggestions. Score of 4 or more, use anticoagulants for 5 to 7 days. Those with a score of 8 for 14 to 30 days. And remember this, Remember these curves. Now, I'm not just exchanging social insincerities when I say that I love Skip, because that's how I got here. Yeah, I told you I was a B student. NISQUIP, exactly. And one of the reasons I love NISQUIP is because they do 30-day data. And look at this. It's an article we published in 2008, thanks to my, not to me, but to my brilliant fellow, Juan Marcellus. 77% of the people in the Riete database, and there's now almost 40,000 people in it, 77% got their clot after hospitalization, and 55% after the anticoagulants stopped. Okay, here's the, you gotta push the right button. Is the orthopedic subset again? The incidence still continues to go up for almost 100 days. And this is the prophylaxis use. This is the incidence of thrombosis. Million women study, 947,000 women followed for 6 years, surgery done in 250,000. Compared with not having surgery, women, I know you know how to read, I'm reading this for emphasis. Women were 70 times more likely to be admitted with venous thrombosis in the first 6 weeks after an inpatient operation and 10 times more likely after a day case operation. The risks were lower but substantially increased for 7 to 12 weeks. And here is, again, and I promise I won't use the term again, astonishing. This is the premier insured database where all incidents, of course, are recorded for reimbursement. And there's 100, these are medical patients, 158,000 patients. Mean day of developing DVT, day 74. Unless, of course, you had congestive heart failure, and then it was day 125. And you know why, because after a while, those congestive heart failure patients, they stop eating right, they stop taking the diuretics, and so as they gain weight, their cardiac output goes down. And I already showed you the cardiac output slide. Not rocket science. Current practice is to administer VTE during hospitalization. Upon discharge, it's assumed that the risk abates. In reality, it really persists. I think I've hammered that home. There's my high-risk score again. Extended prophylaxis is suggested. We already talked about that. Now, the one thing I want to say is that I had this bad fracture. I was in a wheelchair for 3.5 months. And despite all of my fabulous measures, I still had some leg swelling. But within 3 days of walking, the remainder of the leg swelling went away. And it reaffirmed another thing that's in the Caprini box, and that is my definition of immobility. And that is when the calf muscle pump is not working properly. That's somebody in a splint, like this, somebody that's not weight-bearing, a 400-pounder that has to go like this because they don't want to fall over because they weigh so much. And to me, you have to give prophylaxis for the period of time the patient's at risk. And there's an osprey landing on his her nest in Yellowstone. I'm happy to try to answer any questions. Thank you very much. Yes, sir.
You said your high-risk patients home with intermittent pneumatic compression?
If I could, I do. And if I have some really high risk, there's a couple companies now that make portable devices, and one of them is Compression Solutions, and they will rent a unit to a person for 30 days, and yet they send back the unit. And I think it's a very valuable adjunct. We're going to need to do a lot more of that. And also sometimes the people with really high risk, I wore those devices to Hawaii for a flight just for grins, just to see how they work. It's a good idea. So you've seen more of that. Yes, sir.
Are multiple miscarriages considered a risk factor?
Pardon me?
Are multiple miscarriages in women considered a risk factor?
Yeah, it's on the form.
Oh, is it? Okay.
It's a risk. We say 3. And the reason for that is, it's a very good question. The reason for that, and it deserves emphasis, glad you brought it up, is because the antiphospholipid antibody syndrome is something that occurs. And it's a very strange syndrome. It can be congenital or acquired, and a person can develop an allergy to their own proteins. And that includes the clotting proteins. And there's a laboratory definition and a clinical definition. And one of the clinical presentations are miscarriages, multiple miscarriages. Very important. And also, I hear do serum homocysteine in those patients, by the way. Yes, ma'am.
What about genetic studies after a PE? Is that
Well,
easily done?
I'm sorry. I can only, and I'm dead serious about this. I'm not exchanging pleasantries. Here's my box. People were sent to me they had a PE, they had a DVT, maybe they need another operation. Why did I get this? How long do I have to stay on the anticoagulants? What happens if I need another operation? So for me, I do all the common markers. Leiden, prothrombin, anticardiolipid antibodies, beta-2 glycoprotein, homocysteine. I do that first. I don't do protein CNS and antithrombin 3 first because they're so rare. But I do these other markers because that'll depend on how long you treat them. And the other thing is, for length of treatment, I have to see that that scan is, the clots are gone, and they have to have a normal D-dimer and factor VIII level on anticoagulation, and then off anticoagulation. Remember, it's a Caprini box for 30, 90, and 180 days. You get 3 more sets of measurements. If one of those D-dimer or factor VIII goes up in the 6 months, they have an 18% chance per year of a recurrence. If both go up, they have a 34% chance per year of recurrence. If they all stay down, there's still a 6.5% chance of recurrence. Idiopathic thrombosis, especially, once a patient gets a clot, they're always really at risk. But that's the short answer. I'm sorry. Looking very short. Yes, ma'am.
What do you think about compression stacking as opposed to the
Compression stockings are, if you believe in him, work of the devil. And I don't have it in this slide set, but it's in the orthopedic slide set. We measured pressures under the stockings. They don't cause any improvement of blood flow out of the leg. They expand patients with swelling. They create rubber bands. In the stroke studies in medical patients, they didn't work. And so in general, we eliminate them. If a person really needs compression due to swelling, then we put on a proper stocking, which is heavier than that, or a Velcro device, which is another story. But what I would suggest doing is, the only good thing about those stockings, if somebody doesn't have edema, is they're nice liners to absorb perspiration and so forth. So I'd use a tuba grip on the leg that's bigger than the leg, so it doesn't constrict, and then put your SCDs on over that. I wouldn't use any TED. I have the data. You write to me. J. Caprini, too, at AOL. My website is venusdisease.com. The lovely NISQIP team will get you to me. I'll be happy to share any of that, give you more information, whatever you like. Yes, sir. Okay, very, very good question, and I know here in this system a lot of you give anticoagulation before surgery and after surgery, but the question was, what about timing? And in general, preoperative anticoagulation doesn't improve the DVT rate, but it makes us all feel better, but it can increase the bleeding rate. Now, if you're doing a Whipple, then you probably, or a big colon resection or your cancer operations, probably in all of those I'm going to use at least 5,000 units of unfractionated heparin ahead of time. So yes, there are times when we use it. Punishment fits the crimes. So those really higher risk patients, scores over 8, absolutely. Another thing about scores over 8, especially when you get to teens, is sometimes I might screen them post-operative Doppler if it is, because their risk is so high. But yes, there are times, of course, when you should use. You can't use it indiscriminately, and you don't want to use it like, I guess that Europeans never heard of Yogi Berra, because they give their preoperative, they give everybody preoperative low molecular weight heparin 12 hours before orthopedic surgery. The half-life is 4 hours. I'm not making this up. So what do you think is around at the time of surgery? Nothing. So the surgeon is happy, the patient and the family, and everybody's happy because they're preventing DVT. So don't fall into that trap.
When would you use IVC filters for
The bane of my current existence. When would you use IVC filters prophylactically? Almost never is the short answer. IVC filters are to be used for patients who have acute thromboembolic events and they can't be anticoagulated, or if they have full anticoagulation after thromboembolic event and they recur. That's it for the proven indications. The common indications and what's being, so that's it, and that's it according to CHEST. The East Guidelines for Trauma, different story. The East Guidelines for Trauma recommend that they can be used temporarily in very high-risk patients. But the trouble is, when you look at those trauma series, there's an 8 to 30% incidence of post-filter insertion complications. And the thing is, some of those complications are severe: tilting, perforation into the duodenum, perforation into the ureter, perforation into the retroperitoneum with bleeding. And guess who has to take care of those things? With the vascular surgeons. And I know if you call IR, they'll put it in an hour. And the IR guidelines will allow you to do anything you want. If you want to justify a prophylactic filter in every single patient who's had a past history of venous thrombosis, it's in the IR guidelines. So you can do it. But one of the reasons for that is that they're not clinicians. And they don't have to take them out. And they don't have to deal with lifelong post-thrombotic syndrome, recurrent venous thromboembolism, and so on and so forth. So in any event, in summary, be very, very careful of that. And anybody that you do a legitimate consult that says, well, I can go to IR and they can put it in an hour, remind them of that argument I just told you. Next, why can't the patient be anticoagulated? How long has it been since their previous thrombosis? Now, somebody like in the back said that PE patient. Let's say that PE patient was 10 years ago, and after a year or a year and a half, they passed the Caprini box, so they're now no longer on anticoagulants, but their original pulmonary embolism was life-threatening, but it was 10 years ago. They get sideswept off into a barrel pitted roll, and they're in with multiple trauma, and now, oh, they have a history of venous thrombosis. Let's put in a preventative filter. I wouldn't do that first. First of all, there's a good role for screening, even though a lot of people don't recommend it. Secondly, with a distance out from the thrombosis, and depending on the nature of injury, you may be able to start some anticoagulants within a few days afterwards. And the other thing is that don't fall into the pitfall of looking in CHEST and saying that low molecular weight heparin is shown to be more efficacious than unfractionated heparin for DVT and for PE, and so you give it. You can't control it. It has a look. Start an IV heparin drip. It has a 40-minute half-life. You don't like what's going on, shut off the friggin' drip. Give low molecular weight heparin, you're behind the 8 ball. You don't know where you stand. If the renal function is reduced, as it may be in the trauma patient, you're further compromised. If they have hemodynamic compromise, what do you think sub-Q absorption of drugs is in the patient that's hemodynamically compromised? One of the most ridiculous scenarios that I've seen is people that come in with an acute PE and they look at CHEST and they say, low molecular weight heparin is shown in randomized trials to be better than unfractionated heparin. And they give the patient who's got a blood pressure of 90 and is tacking away at 150, they give them a sub-Q heparin shot. They should give them 20,000 unit bolus of IV heparin. And we know if you do that, 93% of them will survive their episode. Only less than 6 or 7% will die in the first hour. Whereas they're probably all going to die because that stuff's not going anywhere. Be stupid. Yes?
When you said a molar
No, usually low molecular weight heparin. But we have a discussion. There's 3 ways you can go. There's low molecular weight heparin. There's sub-Q unfractionated heparin, which is $1 a shot. They'll have to take it 3 times a day. And there's also Coumadin if it's going to be on there for 4 weeks or longer. So you might want to do that. Except if they're cancer patients. Cancer patients should get at least 30 days of low molecular weight heparin. Coumadin has a higher bleeding rate. It has a higher recurrence rate. So those patients need to bite the bullet. As well as patients who have cancer surgery. Let's say a Whipple and post-op, the Whipple gets a PE. Low molecular weight heparin, no Coumadin in that patient. The incidence of bleeding is less, the incidence of recurrence is less, and there is some evidence to suggest it has a life-lengthening effect in certain patients. Last call. Thanks very much.